Okay, let's talk about chronic obstructive pulmonary disease. That's chapter 29. And hopefully, I think I put PowerPoints up, but COPD or chronic obstructive pulmonary disease is probably more of a syndrome than anything. It refers to airflow limitation that is progressive and irreversible, with the exception of cigarette smoking. If someone stops cigarette smoking, this will be able to have some reversibility. So we have chronic bronchitis on one continuum and emphysema on the other continuum, with a bit of asthma mixed in, or bronchospastic kinds of behaviors in the lungs, smooth muscles that can be treated with bronchodilators. It is a large killer of people in our population, third leading cause of death in the U.S. The biggest risk factors: cigarette smoking, and then trailing far behind are occupational chemicals and dust, and then pollution, air pollution. Other factors that come into play are repeated infections, chest infections, but that normally results in chronic bronchitis and eventually bronchiectasis. Hereditary, we can have a deficiency of an enzyme, and aging sometimes. The smokers develop this, not all smokers develop this, but a large portion do. And then mainly people that develop COPD, if they don't quit smoking, they generally die from the COPD. And nicotine has lots of effects. Increases the presence of catecholamines, therefore you have increase in heart rate. It causes vasoconstriction, therefore you have increases in blood pressure and vasoconstriction. So you have increase in blood pressure, increase in cardiac workload. So you have effects on the heart. It affects the amount of oxygen that can be carried on hemoglobin. It increases platelet aggregation, and it's a problem in coronary artery disease. In the respiratory tract, we have a destruction of the cilia that are there to help sweep forward normal production of mucus. You have increased production of mucus. You have local inflammatory responses because of the noxious stimuli of the smoke and the nicotine. And so these things combine to cause eventual damage to the alveoli. Over time, you have a reduced capability of oxygen carrying capacity, so these people tend to be chronically hypoxemic, as they have reduced lung function because they lose alveolar spaces. In other words, their alveoli begin to break down and become, rather than lots of discrete little alveoli, they become many larger alveoli, which reduces the surface area for diffusion of gases. These people are at increased risk for lung cancer and many respiratory symptoms: shortness of breath, dyspnea on exertion, paroxysmal nocturnal dyspnea, and all nutritional deficiencies, increased production of CO2 related to the loss of alveolar diffusion capacity because you have less space to diffuse gases through, so they tend to have chronic hypercarbia, and to compensate over time, you have a chronic elevation in carbon monoxide, bicarbonate. So you normally, chronic obstructive pulmonary disease, blood gases will show you probably a normal pH and then an elevated CO2 and an elevated bicarbonate. That's a kind of a textbook picture. The deficiency that's genetic is called alpha-1 antitrypsin deficiency. It's rare, accounts for 3% of COPD. Over time, our lungs do have some degree of changes that are emphysematous in nature. You have a case study of a 77-year-old man who comes to the hospital complaining of shortness of breath, morning cough, swelling in his lower extremities. He has exercise intolerance, can only walk several feet, and he gets short of breath. So some of the defining features that I mentioned earlier is irreversible airflow obstructions, loss of elastic recoil, so the lungs are stretched out, but they don't have the ability to snap back into a normal shape, and so a normal exhalation is prolonged, and then you have a lot of gas trapping in the distal regions of the lung. A lot of times you have airflow obstruction because of retained secretions and the inability of the cilia to sweep mucus out normally. And then you can have bronchospasm as well. Inflammation, lots of mediators from inflammation, prostaglandins, leukotrienes, all kinds of mediators, interleukins, lots of things that normally go to a place of injury. But you do have destruction in parenchyma. The slide 20 shows a real nice slide of the progression and of what happens with noxious stimuli. Take a minute to look at that and see what happens in the pathophysiology of this disease. Supporting structures in the lung are destroyed. The chest wall becomes barrel-chested over time. The picture on 25 is a representation of what happens when you have destruction between alveolar septum, and they break down and they end up having larger alveoli with very reduced diffusion capacity of gases. Common characteristics, a lot of secretions, dysfunctional cilia, hyperinflation of lungs, which can be seen on a chest x-ray, and gas exchange abnormalities. We can have vascular changes as well in the pulmonary vasculature, and we'll get to that on subsequent recordings.